agents in cardiac arrhythmias. So, cardiac arrhythmias are a common problem in clinic. So it can occur in 20% of patients treated with digitalis. It can occur in 50% of patients who are anesthetized, and over 80% of patients with acute myocardial infarction. So arrhythmias would require treatment because rhythms are too rapid or slow, or asynchronous can reduce your cardiac output. So this can precipitate serious rhythm disturbances. For example, if you have premature ventricular depolarization, it can degenerate into ventricular fibrillation. So antiarrhythmic medication is both saving and pro-arrhythmic. So double blade siya. Life-saving, but sometimes it can also be pro-arrhythmic. So for arrhythmias, this can be managed either by pharmacologic treatment or with non-pharmacologic therapy. So one of the important mechanisms for arrhythmia is your reentry. So when you have reentry circuit, if you still remember in your physiology, this will impact the normal conduction system because of the presence of your reentry circuit. So this can be interrupted by transferring this reentry circuit, radiofrequency catheter ablation, or by cryoablation. So this is application of extreme cold. So the arrhythmias that can be managed by this method or ventricular reentry, your atrioventricular nodal reentry tachycardia using your accessory pathways, your flutter, and your ventricular tachycardia. So there are some forms of ventricular tachycardia that can be ablated. So there are also some recent studies showing that your paroxysmal and persistent atrial fibrillation arise from one of the pulmonary veins. So this becomes the entry circuit, the pulmonary vein. So if you have paroxysmal or persistent atrial fibrillation, this can also be managed by ablation. So pulmonary vein isolation using your RFA or radiofrequency catheter ablation, or by your cryoablation. Or this can also be done by surgery during an open heart surgery. So there are also other forms of arrhythmia that can be managed by implanting your ICDs. So you have your implantable cardiac defibrillator. So this is another form of non-pharmacologic therapy where you implant a device, and this will automatically detect and treat potentially life-threatening arrhythmias like your ventricular fibrillation. So before we proceed with the different drugs used for the management of arrhythmia, let's first review the anatomy and physiology of your cardiac function conduction system. So this is your sinus node. So it is located in your right atrium. So your sinus node is the natural pacemaker of the heart. It conducts at a rate of 60 to 100 beats per minute at rest. Then from your sinus node, the electrical impulse will proceed down to your AV node. So your atrioventricular node will receive impulse from your SC node and delivers the impulse to the His-Purkinje system. So if your SA node fails to fire, your AV node can take over. So it can deliver impulse pulse at a rate of 40 to 60 beats per minute. So slower than your SA node. Then from your AV node, the pulse will proceed or will be transmitted down to your bundle, to your his bundle, down to your bundle branches, your right and left bundle branch, to your his Purkinje system. So the conduction here now begins to, the impulse, I mean, begins to be conducted down to your ventricle. So your AV junctional tissue actually conduct impulse at a rate of 40 to 60 beats per minute. And then, as I've said, it will be conducted down to your bundle branches and to your Purkinje fibers. So this is collectively called as your Purkinje network, and it will move the impulse through the ventricles for contraction, and it provides an escape rhythm of 20 to 40 beats per minute. So do you still remember this? What do you call this? So this is your action potential. So this is your action potential and will cause the depolarization and repolarization of your ventricle. So you have your phases of your action potential, your phase 0, which is your rapid depolarization. And this is mainly determined by influx of sodium into your myocardial cells, followed by influx of calcium, and this will produce a slow inward current. Your phase 1 to 3, this is the repolarization phases of your action potential, and this is primarily related to the outward flux of your potassium. And then your phase 4, which is your resting membrane potential. So this is another way of presenting your action potential, now associated with the different potential currents or the principal current. So potassium current is actually the principal current during phase 4. So during your resting. And this will determine the resting membrane potential of your myocyte. The sodium current, so the sodium current generates the upstroke of your action potential. So your phase 0, so this is your upstroke. And it will activate your ITO. With inactivation of the sodium current, this will also inscribe early repolarization. So you have your phase 1 already. So pag inactive na nimo sodium current, so it will inscribe this one, which is your phase 1 of your early repolarization. Then you have your plateau. So that's phase 2, and this is generated by a balanced repolarizing potassium currents and depolarizing calcium current. So inactivation of the calcium current with persistent activation of potassium currents will cause your phase 3 repolarization. So the transmembrane potential of cardiac cells is determined by the concentrations of several ions. So these are chiefly your sodium, your potassium, calcium, and your chloride on either side of the membrane, and the permeability of the membrane of each ion. So these channels primarily are responsible for cardiac potentials, and they are opened and closed by voltage changes across the cell membrane. So they are gated. So usually these gated channels are voltage sensitive. So they are also modulated by ion concentrations and metabolic conditions, and some potassium channels are also primary ligand rather than voltage sensitive, but mostly they are voltage sensitive. So the conductance of the fast sodium channel will increase or increases in response to a depolarizing stimulus. When your calcium enters, the potassium will leave the cell with its action potential. So the cell maintains stable transmembrane ionic conditions by establishing and maintaining your ion gradients. So the most important of this active mechanism is your sodium pump or sodium potassium ATPase. So this pump and other active ion carriers contribute indirectly to the transmembrane potential by maintaining the gradients necessary for diffusion through the channels. So what's the effect of your potassium? So in the heart, changes in serum potassium concentration can alter your potassium conductance independent of simple changes in your electrochemical driving force, and oftentimes this effect predominates. So the actual observed effects of hyperkalemia are a reduced in your action potential duration. It will slow its conduction. It will also decrease your pacemaker rate and decrease your pacemaker arrhythmogenesis. So the actual observed effects of hypokalemia are prolonged action potential duration, increased pacemaker rate, and increased pacemaker arrhythmogenesis. So mag-opposite. So pacemaker rate and arrhythmias involving ectopic pacemaker cells appear to be more sensitive to changes in your serum potassium concentrations compared with cells of your sinoatrial node. So these effects on the heart will contribute to the observed increased sensitivity to potassium channel blocking arrhythmogenic agents during hypokalemia. Example, in your accentuated action potential prolongation and your tendency to cause your torsade de poids. So in normal atrial, Purkinje, and ventricular cells, the action potential upstroke is dependent on your sodium current. So your phase 0 is dependent on your sodium current. So the cardiac sodium channel protein has been cloned, and this is now recognized to represent different protein conformations. So regions of the protein that will confer specific behaviors such as voltage sensing, poor formation, and inactivation are now being identified. So depolarization to the threshold voltage will result in the opening of the activation gates of your sodium channels. Now, if the inactivation gates of these channels are not closed, the channels are opened or activated, and the sodium permeability is increased, markedly increased, exceeding the permeability for any other ion. Now, your extracellular sodium, therefore, diffuses down its electrochemical gradient into the cell. So the cell membrane potential very rapidly approach the sodium equilibrium potential. So this is the about 70, the equilibrium potential. So this intense sodium current is very brief because of the opening of the M gates upon depolarization, and is promptly followed by closure of the H gates and inactivation of the sodium channels. So most of your calcium channels, become activated and inactivated the same way as your sodium channels. The action potential plateau, which is your phase 1 and 2 of your action potential, reflects the turning off of most of your sodium current. So the waxing and waning of calcium current and the slow development of a repolarizing potassium current. So your phase 3, which is final phase of your repolarization, results from the completion of your sodium and calcium channel inactivation and the growth of potassium permeability, so that the membrane potential once again approaches the potassium equilibrium potential. So the major potassium currents involved in phase 3 repolarization are the rapidly activating potassium current and the slowly activating potassium current. So these are the ones which are involved. So this actually explains why some drugs that block either your rapidly activating potassium current and slowly activating potassium current may prolong repolarization in the Purkinje ventricular cells, but they have little effect on the sinoatrial nodal repolarization. So there are also some genetic basis for molecular and genetic basis for your cardiac arrhythmias. So your molecular bases are usually the cause for several of your congenital and acquired cardiac arrhythmias. So example are your polymorphic VT, which is also called or known as your torsade de poids. And this is associated with a prolongation of your QT interval, especially at the onset of the tachycardia. So this may cause syncope and even sudden death in some of those patients who develop torsade. So this is actually attributed to an increased inward current or a decreased outward current during the plateau of the action potential. So the potassium channel, which is your rapid current, potassium current, is blocked or modified by many of your drugs that is used for arrhythmia. So an example of these antiarrhythmic medications are your Kinetin and your sotalol, or from electrolyte abnormalities like hypokalemia, hypomagnesemia, and hypocalcemia. And all these may produce your torsade. So identification of the precise molecular mechanisms underlying various forms of long QT syndromes raises the possibility that specific therapies may be developed. So there are preliminary reports already suggesting that your sodium channel blocker like Mexiletine can correct the clinical manifestations of congenital long QT subtype 3 syndrome. So it is also likely that torsade de poids originates from triggered upstroke arising from early after the polarizations. So therapy here is directed at correcting hypokalemia as well as eliminating triggered upstrokes by using your blockers or magnesium, or shortening the action potential by increasing your heart rate with isoproterenol or pacing. So all this may correct. So there are 3 forms of your short QT syndromes that have been identified, and they are linked to gain of function mutations in 3 different potassium channel genes. So these are your KCNH2, your KCNQ1, and your KCNJ2. So your catecholinergic polymorphic ventricular tachycardia, these are disease that is characterized by stress or emotion-induced syncope. So this can be caused by genetic mutations in 2 different proteins in the sarcoplasmic reticulum that control your intracellular calcium homeostasis. The mutations in your 2 different ion channel genes, your HCN4 and SCN5A, have also been linked to congenital forms of sick sinus syndrome. So one form of for sudden cardiac death is your Brugada syndrome. So the Brugada syndrome is characterized by ventricular fibrillation. This is associated with a persistent ST segment elevation and progressive cardiac conduction disorder. And this is also characterized by impaired conduction in the His-Purkinje system and a right or left bundle block leading to complete atrioventricular block. So they have been both linked to several loss of function mutations in the sodium channel gene SCN5A. Familial atrial fibrillation is another congenital form of arrhythmia, and this is caused by a gain of function mutation in the potassium channel gene KCNQ1. So what are the effects of resting potential on your action potentials? So the key factor in the pathophysiology of arrhythmias and the actions of your antiarrhythmic drugs is the relation between the resting potential of a cell and the action potential that can be evoked in it. So the important consequences of the reduction in peak sodium permeability include a reduced maximum upstroke velocity, so your Vmax, the reduction in your action potential amplitude, as well as reduction in your excitability and reduction in your conduction velocity. So these are some of the important consequences of the reduction in your peak sodium permeability. So during plateau of the action potential, the sodium channels are inactivated. So during repolarization, so you have recovery from inactivation. This will take place, making the channels again available for excitation. So the time between phase 0 and recovery of sodium channels in phase 3 to permit a new propagated response to an external stimulus is your refractory period. So changes in your refractoriness is an important factor in the genesis or suppression of certain arrhythmias. So another important effect of less negative resting potential is the prolongation of this recovery time. So prolongation of recovery time is reflected in an increase in the effective refractory period. So what are the different mechanisms of arrhythmias? So there are factors that can or exacerbate arrhythmias. So this includes ischemia, hypoxia, acidosis or alkalosis. You have your electrolyte abnormalities, excessive catecholamine exposure, autonomic influences, drug toxicities, overstretching of cardiac fibers, and presence of scarred or otherwise diseased tissue. So the mechanism for cardiac arrhythmias include a disturbances in impulse formation, or it could be from a disturbance in impulse conduction, so impulse formation, impulse conduction, or both. So let's take a look at pulse. So disturbances in your impulse formation. So the interval between depolarization of a pacemaker cell is the sum of the duration of the action potential and the duration of the diastolic interval. So shortening of either duration will result in an increase in your pacemaker rate. So vagal discharge and receptor blocking drugs will slow the normal pacemaker rate by reducing the phase 4 slope. Now, acceleration of the pacemaker discharge brought about by increased phase 4 depolarization slope can be caused by hypokalemia, by your adrenoceptor stimulation, or from the effect of your positive chronotropic drugs, your fiber stretch, or the presence of acidosis and partial depolarization by current of injuries when you have ischemia or myocardial infarction. So after depolarizations are depolarizations that interrupt phase 3. So this could be early after depolarization. So the interruption is early on, and you have your delayed after depolarization, which occurs during the phase 4. So kung early, during phase 3. So interruption of your phase 3 of your action potential. If it's interruption of phase 4, it's your delayed after depolarization or your DADS. Your early after depolarizations are usually exacerbated at slow heart rates and are thought to contribute to the development of your long QT related arrhythmias. Your DADS often occur when the intracellular calcium is increased. So this can be exacerbated by fast heart rates, and they are thought to be responsible for some arrhythmias related to digitalis excess, to catecholamines, and to myocardial ischemia. So this is a schematic diagram of how your after depolarization and your early after depolarization and delayed after depolarization occurs. So, diba, your early after depolarization, it interrupts your phase 3 of your action potential, and your delayed after depolarization interrupts your phase 4 of your action potential. So your early after depolarization is actually due to the activation of your L-type calcium current, while your delayed after depolarization is due to intracellular calcium overloading. So if you have a severely depressed conduction, this may result in a simple block. So like you can have an atrioventricular nodal block or a bundle branch block. So partial atrioventricular block is sometimes relieved by atropine. So you can give your atropine to relieve the block. So if it's a partial atrioventricular block. If it's a reentry, also known as your circus movement, so the common abnormality of conduction, this is a common abnormality of conduction in which one impulse re-enters and excites areas of the heart more than once. So circus, pabalik-balik. So that's why it's called re-entry. So this is actually how re-entry works. So in a normal tissue, so this is a normal tissue. If you have a single fiber, so you have a single fiber, this one, and then it forms two branches. You have your branch 1 and branch 2. So the action potential will travel down each branch. So if you put an electrode here in a side, so this is a side branch, it would record a single normal action potential as they are conducted down branch 1 and into the side branch. Now, if branch 1 and 2 are connected together, this one by a common connecting pathway, the action potentials that travel into this branch, your branch 3, will cancel each other. So that is normal. So what happens if there is re-entry? So re-entry can occur if, for example, branch 2 has a unidirectional block. So ito, yung gray. So impulses will travel retrograde, actually from branch 3, tapos pabalik retrograde. So let's start first here. So the action potential will travel from branch 1 into the common here, distal path. And then it will travel retrogradely into the here, a block, this one, through the unidirectional block in branch 2. Kasi kung dito, hindi naman siya makaka-enter. So dito siya retrograde. So within the block. So the conduction velocity here is reduced because of depolarization. When the action potential exceeds the block, so pakagawas niya, once it exceeds the block, and then it finds the tissue to be excitable, then the action potential will continue by traveling again down. So, pabalik-balik niya circus. Down branch 1 and then go back. Now, if the action potential exceeds the block in branch 2 and finds the tissue unexcitable, then the action potential will die. So, walang propagation of your arrhythmia. So, it will only propagate once this retrograde will find an excitable. So, this action potential finds an excitable tissue. Pero pag the tissue, it exits and finds an unexcitable tissue, it will not propagate. Okay? So for reentry to occur, 3 conditions must exist or coexist. So there must be an obstacle, meaning an anatomic or a physiologic obstacle to your homogeneous conduction, establishing a circuit around which the reentrant wavefront can propagate. Then second, there must be a unidirectional block at some point in the circuit. That is, conduction must die out in one direction, but continue in the opposite direction. And third, conduction time around the circuit must be long enough that the retrograde impulse does not enter refractory tissue as it travels around the obstacle. So that is, the conduction time must exceed the effective refractory period. So let's look at the mechanism of actions of some of your antiarrhythmic medications. So I've said arrhythmias are caused by abnormal pacemaker activity or abnormal impulse propagation. So the aim of your antiarrhythmic medication is to reduce your ectopic pacemaker activity as well as modify conduction or refractoriness in the reentry circuit to disable the circus movement. So there are 4 major mechanisms for accomplishing these goals. So you can block your sodium channel, or you may block the sympathetic autonomic effects of the heart, or you can prolong the effective refractory period, or block the calcium channel. So cells with abnormal automaticity. So most of the drugs reduce the phase 4 slope by blocking either the sodium or the calcium channels, thereby reducing the ratio of your sodium permeability to potassium permeability. So your adrenal receptor blocking drugs indirectly reduce this phase 4 slope by blocking the positive chronotropic actions of norepinephrine in the heart. So in reentry arrhythmias, agents slow conduction further by one or both of the 2 mechanisms. So your steady state reduction in the number of available unblocked channels, which will reduce the excitatory currents to a level below that is required for propagation. And second, by prolongation of your refractory recovery period or recovery time of the channels. So by these mechanisms, your antiarrhythmic drugs can suppress your ectopic automaticity and abnormal conduction occurring in the depolarized cells. We need to say it will render them electrically silent while minimally affecting the electrical activity in normally polarized parts. the heart. So when the dosage is increased, these agents also will depress conduction in normal tissue. So eventually, it may result to drug-induced arrhythmias. That's why, as I've said, your antiarrhythmic medications are both antiarrhythmic and proarrhythmic. So proarrhythmic, it becomes proarrhythmic during fast heart rates, also in acidosis, like it can slow the recovery from block for most of the drugs in the presence of hyperkalemia or in ischemia. So there are 4 classes of your antiarrhythmic agents. So you have your class 1, 2, 3, and 4. So class 1 is further subdivided into 3 classes, your ABC. So class 1 are your sodium channel blockers. So this will cause sodium channel blockade. And your class 1A, the action potential, the action here of your medication will prolong the action potential duration and dissociate from the channel with intermediate kinetics. So your class 1B will shorten the action potential in some tissues of the heart and dissociate from the channel with rapid kinetics. Your class 1C, they have minimal effects on the action potential duration and dissociate from the channel with slow kinetics. So class 2 are sympatholytic. So these are sympatholytic drugs. So drugs with this action will reduce the adrenergic activity in the heart. Class 3, this will manifest as prolongation of your action potential duration. So most drugs with this action block, with this action will block the rapid component of the delayed rectifier potassium current. While your class 4, these are calcium channel blockers. So this will block your calcium current and it will slow the conduction in the region where the action potential upstroke is calcium dependent. So like your sinoatrial and your atrioventricular nodes or your AV nodes. So for class 1, or your sodium channel blocking drugs, these drugs have local anesthetic action. So this will block your sodium channels and will reduce the sodium current. And this is actually the oldest group of antiarrhythmic drugs, and they are still widely used. So under your sodium channel blockers are your Brocanamide. So your Brocanamide belong to subgroup 1A. So its cardiac effects include the blocking of your sodium channels. It will slow the upstroke of the action potential. It will also slow the conduction and prolong the QRS duration of the ECG. The drug also will prolong the action potential duration by non-specific blockade of the potassium channels. It is less effective than Kinetin in suppressing abnormal ectopic pacemaker activity, but it has a direct depressant action on the sinoatrial and atrioventricular nodes. So the extracardiac effects of Brocanamide include ganglion blocking properties. This will reduce peripheral vascular resistance and can cause hypotension. So hypotension is usually associated with excessively rapid Brocanamide infusion or presence of severe underlying left ventricular dysfunction. The toxicities of Brocanamide includes excessive action potential prolongation, QT interval prolongation, and induction of your torsade de poids and syncope. It may also cause a syndrome resembling your lupus erythematosus. So this is actually the most troublesome adverse effect with long-term use of your Brocanamide. This consists, your syndrome consists of arthralgia and arthritis, pleuritis, pericarditis, or parenchymal pulmonary disease. Renal lupus is rarely induced by Brocanamide. So serologic abnormalities can also occur in nearly all patients. So they may have a positive or an increase in your anti-nuclear antibody titer. So this syndrome, your lupus-like syndrome, develops in 1/3 of patients receiving long-term Brocanamide therapy. So other adverse effects includes nausea and diarrhea in about 10% of cases, rash, fever, and hepatitis in 10% of cases, in less than 5% of cases, and agranulocytosis in approximately 0.% of cases. So Brocanamide can be administered safely by IV and IM routes. It is also well absorbed orally. Your metabolite, N-acetyl Brocanamide, or your NAPA, has class 3 activity. So excessive accumulation of NAPA has been implicated in torsadequat during Brocanamide therapy, especially in patients with renal failure. So some individuals also may rapidly acetylate Brocanamide. So they may develop also high levels of your NAPA. So Brocanamide is eliminated by hepatic metabolism to NAPA, and by renal elimination. So the half-life is 3 to 4 hours, and NAPA is eliminated by the kidneys. So dosage should be reduced in patients with renal failure. So the half-life of NAPA is longer than that of Brocanamide. So it's very important to measure the plasma levels of both Brocanamide and NAPA, especially in patients who have circulatory or renal impairment. So if rapid Brocanamide effect is needed, so you give an IV loading dose of up to 12 milligrams per kilogram, and this can be given at a rate of 0.3 milligrams per kilogram per minute or less rapidly, and then followed by the maintenance of 2.2 to 5 milligrams per minute, and you need to monitor the plasma levels. So risk of GI or cardiac toxicity rises at plasma concentrations greater than 8 micrograms per ml or NAPA concentrations greater than 20 micrograms per ml. Ventricular arrhythmias. So the dose is 2 to 5 grams per day to control your ventricular arrhythmias. So the Brocanamide is effective against atrial and ventricular arrhythmias. It's the second or third choice in most coronary care units for the treatment of sustained ventricular arrhythmias associated with acute myocardial infarction. So next is your Kinetin. So Kinetin belong also to subgroup 1A. So your Kinetin will slow the upstroke of the action potential and conduction and prolong the QRS duration of ECG by blocking your sodium channels. It will also prolong the action potential duration by blocking several potassium channels. The toxic cardiac effects include excessive QT interval prolongation and induction of your torsadequat arrhythmia. Toxic concentrations may also produce excessive sodium channel blockade with slowed conduction throughout the heart. So the extracardiac effects of Kinetin include GI manifestations like diarrhea, nausea, and vomiting. So they are usually observed in 1/3 to half of patients receiving Kinetin. Synchronism is a syndrome of headache, dizziness, and tinnitus that is observed with Kinetin toxicity. So you can also have it. This is an idiopathic or immunologic reaction, including thrombocytopenia, hepatitis, your angioneurotic edema, and fever, although these are rare manifestations. So the drug is readily absorbed from the GI tract and is eliminated by hepatic metabolism. So this is now rarely used because of some cardiac and extracardiac adverse effects. So next is your Dissopyramide. So it also belongs to group 1A. It has similar effects to your Brocanamide and Kinetin. So it has also a cardiac anti-muscarinic effects, and they are even more marked than those that is observed with Kinetin. So it will slow your atrioventricular conduction. So the drug can be administered with Dissopyramide when treating your atrial flutter or fibrillation. So toxicity of your Dissopyramide can precipitate all of your electrophysiologic disturbances observed with Kinetin. So the drug or your Dissopyramide has negative inotropic effect. So therefore, it may precipitate heart failure de novo or in patients with pre-existing depression of your left ventricular function. So it should not be used in patients with heart failure. So it also has an atropine-like activity, and this accounts for most of its symptomatic adverse effects like urinary retention, dry mouth, blurring of vision, constipation, and worsening of a pre-existing glaucoma. So in the US, you have an available oral medication, Dissopyramide. So the typical oral dosage of your Dissopyramide is 150 milligrams 3 times a day, but up to 1 gram per day has been used. For those with renal impairment, you have to modify the dose or reduce the dose. So loading dose is not recommended because of the danger of precipitation of your heart failure. For therapeutic use, Dissopyramide has been shown to be effective in a variety of supraventricular arrhythmias. So in the US, it is approved for treatment of ventricular arrhythmias. So next is Lidocaine. So Lidocaine belongs to subgroup 1B. It has lower incidence of toxicity and has a higher degree of effectiveness in arrhythmias associated with acute myocardial infarction. But this one is used only via IV route. So Lidocaine blocks the activated and inactivated sodium channels with rapid kinetics. So the inactivated state block ensures greater effects on cells with long action potential, such as your Purkinje and your ventricular cells, compared to your atrial cells. So the toxicity, it is less. It has the least cardiotoxic effects among your sodium channel blockers. But it has pro-arrhythmic effects, including sinoatrial node arrest, worsening of impaired conduction, and ventricular arrhythmias. In large doses, especially those with pre-existing heart failure, it may cause hypotension, partly by depressing your myocardial contractility. So the most common adverse effects include neurologic, like paresthesia, tremors, nausea of central origin, lightheadedness, hearing disturbances, slurring of speech, and convulsions. These adverse effects are commonly seen in the elderly population, those vulnerable patients, or when you give a bolus of the drug that is given rapidly. So the effects are dose-related and short-lived. Seizures here may respond if the patient develops seizure, may respond to your intravenous diazepam. So lidocaine is given parenterally, and it has a half-life of 1 to 2 hours. The loading dose is 150 to 200 milligrams administered over 15 minutes. And then this should be followed by maintenance infusion of 2 to 4 milligrams per minute to achieve a therapeutic plasma level of 2 to 6 micrograms per ml. So in heart failure patients, lidocaine's volume of distribution and total loading and maintenance doses should be decreased. Now, in patients also with liver disease, the plasma clearance is markedly reduced and the volume of distribution is often increased. So the maintenance dose should be decreased also, but the usual loading dose can be given. So your lidocaine is the agent of choice for termination of ventricular tachycardia and prevention of ventricular fibrillation after cardioversion in the setting of acute ischemia. So routine prophylactic use of lidocaine may increase total mortality by increasing the incidence of asystole. So that's why lidocaine is not given as prophylaxis in patients who have myocardial infarction. We know that patients with myocardial infarction are vulnerable to ventricular arrhythmias, but you do not give your lidocaine as prophylaxis para hindi sila mag-develop ng ventricular fibrillation or ventricular tachycardia because it will increase the incidence of asystole. We only give that kung the patient already developed ventricular tachycardia or ventricular fibrillation. So another antiarrhythmic medication belonging to subgroup 1B is your mexiletine. So this is an orally active congener of lidocaine. So its electrophysiologic and antiarrhythmic actions are similar to those of lidocaine. So it's used for ventricular arrhythmia. Including tremors, blurring of vision, and lethargy. Nausea is also common with mexiletine. So mexiletine can also be used for relieving chronic pain, especially pain due to diabetic neuropathy and nerve injury. The dose is 450 to 750 milligrams per day already. So this is off-label. Flickening is another antiarrhythmic medication belonging to class 1, but it belongs to 1C, subgroup 1C. So your flickenamide is a potent blocker of your sodium and potassium channels with slow and blocking kinetics. So the drug is currently used for patients with otherwise normal hearts who have supraventricular arrhythmias, meaning to say they don't have structural cardiac abnormalities, structural heart disease. So they have normal hearts, but they develop arrhythmias like your SVTs or atrial fibrillation. So it has no muscarinic effects. So it's effective in suppressing premature ventricular contractions, and it may cause severe exacerbations of arrhythmias even with normal doses. So it's well absorbed and has a half-life of 20 hours. The elimination is both by hepatic and kidney. The dose of Flickening is 100 to 200 milligrams twice daily. So propafenone is an antiarrhythmic drug belonging to subgroup 1C with structural similarities to propranolol and possesses weak blocking activity. So the spectrum of action is similar to your Kinetin. It does not prolong the action potential. The sodium channel blocking kinetics are similar to Flickening. So it is metabolized in the liver with an average half-life of 5 to 7 hours. And the daily dose of propafenone is 450 to 900 milligrams in 3 divided doses. So this is being used primarily for supraventricular arrhythmias. The most common adverse effects are metallic taste and constipation. Arrhythmia exacerbations can also occur with the use of your propafenone. Morisicin is belong to your subgroup 1C. So it's an antiarrhythmic phenothiazine derivative that was used for treatment of ventricular arrhythmias. So it's a potent sodium channel blocker that does not prolong the action potential duration. So next class is your beta adrenoceptor blocking drugs, or your class 2 antiarrhythmic medications. So you have your propranolol and similar drugs. So they have antiarrhythmic properties by virtue of their receptor blocking action and direct membrane effects. So some of these drugs have selectivity for cardiac 1 receptors. Some have intrinsic sympathomimetic activity. They have marked direct membrane effects, and some will prolong the cardiac action potential. So the drug is well tolerated, and their efficacy for suppression of your ventricular ectopic depolarization is lower than that of your sodium channel blockers. So these agents can prevent recurrent infarction and sudden death in patients recovering from acute myocardial infarction. So ismolol is a short-acting blocker used primarily as an antiarrhythmic drug for intraoperative and other acute arrhythmias. Sotalol is a non-selective blocking drug that prolongs the action potential. So it prolongs your action potential by blocking the potassium channels in the cardiac muscle, or by enhancing the inward current through your sodium channels. So your action prolongation by most of these drugs will inhibit the undesirable property of reverse use dependence. So action prolongation is least marked at fast rate and most marked at slow rates, where it can contribute to the risks of torsade de poids. So it may also evoke QT prolongation. So amiodarone, so in the US, this has been approved for oral and intravenous use to treat serious ventricular arrhythmias. So the drug is also highly effective for treatment of supraventricular arrhythmias such as atrial fibrillation. Dronadarone is also an analog that lacks your iodine atoms. So this is a new drug. Actually, it's not a new drug. I don't know kasi hindi na siya available in the market. So your amiodarone markedly prolongs the action potential duration by blocking your rapid potassium channels. With chronic administration, it will block also your slow potassium channels. So the action potential duration is prolonged uniformly over a wide range of heart rate. So meaning the drug does not have reverse use dependent action. So its present classification is under class 3. So amiodarone is under class 3. The drug also significantly blocks inactivated sodium channels. Its action potential prolonging action reinforces also this effect. So it has a weak adrenergic and calcium channel blocking actions. So consequences of these actions would include slowing of the heart rate and atrioventricular node conduction. And the broad spectrum of actions account for the high efficacy and low incidence of your torsade with the use of your amiodarone. So extra cardiac effects include peripheral vasodilatation. That's why you have to use amiodarone with caution in patients who have borderline blood pressure or even in hypotensive patients, because it may aggravate hypotension or cause hypotension. So this prominent after intravenous administration may be related also to the action of the vehicle. Amiodarone can cause symptomatic bradycardia and heart block in patients with pre-existing sinus or atrioventricular node disease. So the drug accumulates in many tissues, including the heart, lung, liver, and skin. And this is concentrated also in tears. So the pulmonary toxicity is dose-related, and this is the most important adverse effects observed with long-term use of your amiodarone. So you can have fatal pulmonary fibrosis, and this is observed in 1% of cases. They may also develop abnormal liver function tests and hepatitis. There could also be some skin deposits that is a result of your photodermatitis and a gray-blue skin discoloration in the sun-exposed areas and in the malar regions. Asymptomatic corneal microdeposits also may be observed. So these microdeposits, corneal microdeposits, could lead to halos that develop in peripheral visual fields of some patients. Discontinuation of the drug is not required. So rarely the drug may cause optic neuritis, but this may also may progress to blindness. So hyperthyroidism or hypothyroidism may also develop. So amiodarone is variably absorbed with bioavailability of 35 to 65%. So it undergoes hepatic metabolism, and major metabolite is your desethyl amiodarone. So this is bioactive. So the complex elimination half-life has a rapid component of 3 to 10 days and a slower component of several weeks. So the effect is maintained for 1 to 3 months. So you can give a loading dose of 10 grams, and this is achieved with 0.8 to 1.2 grams daily doses. The maintenance dose is 200 to 400 milligrams daily. So if you want a rapid effect, so you can give the IV loading dose of the medication. So amiodarone is a substrate for liver cytochrome P3A4. So, and its levels are increased by the drug that inhibit this enzyme. So it has interactions with your histamine or H2 blocker, cimetidine. So drugs that will induce your CYP3A4, like rifampicin, will decrease your amiodarone concentration when co-administered. So these are some of the interactions. So it will increase when you give it concomitantly with your histamine blocker. It will decrease your amiodarone concentration if you give it concomitantly with your rifampicin or rifampin. So it also inhibits other liver cytochrome metabolizing enzymes and may result in high levels of the drug that are substrates for these enzymes like digoxin and warfarin. So low doses of amiodarone are effective in maintaining normal sinus rhythm in patients with atrial fibrillation. It is also effective in the prevention of recurrent ventricular tachycardia. Dronedarone is a structural analog of amiodarone. So it lacks the iodine atoms, and this is intended to eliminate the action of the parent drug on thyroxine metabolism and to modify the half-life of the drug. So it has multiple actions. So it will block your slow, your rapid, your calcium, and your sodium current channels. And it's also an adrenoceptor. So it has a half-life of 24 hours. It is administered twice daily. And this is the first antiarrhythmic drug to demonstrate a reduction in mortality or hospitalization in patients with atrial fibrillation. Vernaculant is an investigational multi-channel blocker that was developed for the treatment of atrial fibrillation. It prolongs the atrial effective refractory period and slows conduction over the atrioventricular node. Maximal clinical dose of 1,800 milligrams per day. Your vernaculant will not change the QT interval on the ECG. So it blocks your potassium, your acetylcholine, and your TO channels, or your your channels. These currents play key roles in atrial repolarization, and their blockade accounts for the prolongation of your atrial ERP. So they are less potent blocker of your rapid potassium channels and produces less action potential prolongation in the ventricle. So it also produces rate-dependent blockade of your sodium channel. So vernaculant will cause disturbance in your taste or dysgeusia. It may cause sneezing, paresthesia, cough, and hypotension. So after administration of the drug is metabolized in the liver by CYP2D6. So it has a half-life of 2 hours. The regimen of 900 milligrams twice daily will be sustained in your blood concentration and for a 12-hour interval. While your intravenous, this is effective in converting your recent onset atrial fibrillation to normal sinus rhythm in 50% of patients. Sotalol has both beta-adrenergic receptor blocking and an action potential prolongation action. So the racemic mixture of your D and L sotalol. All of this alpha beta adrenergic blocking activity resides in the L isomer, and the D and L isomer share the action potential prolonging action of sotalol. So the drug is well absorbed orally with bioavailability of approximately 100%. So it's not metabolized in the liver and it's not bound to your plasma protein. So it is excreted predominantly by the kidney in the unchanged form. So the half-life is 12 hours, and those related incidents of torsade de pois has been observed, approach 6% at the highest recommended daily dose. So overt heart failure also may be noted with further depression of left ventricular function. So it increases the threshold for cardiac defibrillation. Dofetilide is a class 3, or it has a class 3 action potential prolonging action. So it is dose dependent. The blockade is dose dependent of the rapid component of the delayed rectifier potassium current, and the blockade of your rapid potassium current increases in hypokalemia. So its bioavailability is 100%, and verapamil increases your peak plasma of your dofetilide concentration by increasing the intestinal blood flow. So 80% of the oral dose is eliminated by kidneys and change. The remainder is eliminated in the urine as inactive metabolites. So if given together with cimetidine, it will prolong the half-life of your dofetilide. QT prolonging effects of the drug and the risk of ventricular proarrhythmia are directly related to the plasma concentration. So dosage must be based on the estimated creatinine clearance. So treatment with dofetilide should be initiated in hospital after baseline measurement of the rate-corrected QT interval and serum electrolytes. So you need to get the QT interval. So baseline QT of more than 450 milliseconds or bradycardia of less than 50 beats per minute and hypokalemia are relative contraindications with the use of your dofetilide. Dofetilide is approved for maintenance of normal sinus rhythm in patients with atrial fibrillation. So ibutilide slows the cardiac repolarization by blocking the rapid component of the delayed rectifier potassium current. So the activation of your it will activate the slow inward sodium current. It is rapidly cleared from the plasma by hepatic metabolism. So the metabolites are excreted via the kidney. The elimination half-life is 6 hours. This is used for acute conversion of atrial flutter and atrial fibrillation to normal sinus rhythm. So the drug is more effective in atrial flutter than atrial fibrillation, with a mean time to termination of 20 minutes. Most important adverse effect is excessive QT prolongation and torsade de pois. So verapamil belong to class 4. So they are classified under calcium channel blocking drugs. So your verapamil blocks both activated and inactivated type calcium channels. So its effect is more marked in tissues that fire frequently, those that are less completely polarized at rest, and those in which activation depends exclusively on the calcium currents, such as your SA node and your AV nodes. So AV nodal conduction time and effective refractory period are prolonged by therapeutic concentrations of verapamil. So it will suppress both the early and delayed after depolarization. The extracardiac effects include peripheral vasodilation, which may be beneficial in hypertension and peripheral vasospastic disorders. The cardiac toxicities are dose-related and usually avoidable. So it has negative inotropic effects. So this may limit its clinical usefulness in diseased hearts. So that's why verapamil is not used in patients who already have reduced ejection fractions. So this can induce atrioventricular block when used in large doses or in patients with atrioventricular nodal disease. So adverse extracardiac effects include constipation, lassitude, nervousness, and peripheral edema. So the drug has a half-life of 7 hours and it is extensively metabolized by the liver. The oral administration, the viability is about 20%. So this should be administered with caution in patients with hepatic dysfunction. With parenteral verapamil, this can be used to terminate SVT. The dose is 5 milligrams initially as bolus, given in 2 to 5 minutes, followed by 5 milligram bolus, a second 5 milligram bolus if needed. Then thereafter, you can give 5 to 10 milligrams given every 4 to 6 hours, or a constant infusion of 0.4 micrograms per kilogram per minute. So this is effective. The effective oral dosage are higher than your intravenous dosage because of the first pass effect. So the range is 120 to 640 milligrams daily divided into 3 or 4 doses. So verapamil is used for supraventricular tachycardia. This can also be used to reduce the ventricular rate in atrial fibrillation and flutter, but it rarely converts atrial flutter and fibrillation to sinus rhythm. The Lidocaine has similar efficacy to verapamil in the management of supraventricular arrhythmias, including rate control in atrial fibrillation. So an intravenous form of the Lidocaine is available for the latter indication and will also cause hypotension or bradyarrhythmias. So some of the antiarrhythmic drugs that has been used and they are not classified based on the classifications of your antiarrhythmic is your adenosine. So adenosine is a nucleoside that occurs naturally throughout the body. So it has a half-life in the blood of less than 10 seconds. So the mechanism of action involves activation of an inward rectifier current, potassium current, and inhibition of your calcium current, so resulting in marked hyperpolarization and suppression of calcium-dependent action potentials. So you give the dose in bolus. So bolus dose. The bolus dose of your adenosine directly inhibits your AV node conduction, and it will increase the anodal refractory period, but it has lesser effects on your SA node. So adenosine is the drug of choice for prompt conversion of paroxysmal supraventricular tachycardia to sinus rhythm because of its high efficacy. So 90 to 95% and very short duration of action. So it's given in a bolus dose of 6 milligrams followed if necessary by another dose of 12. So you double the dose, 12 milligrams. So it's less effective in the presence of adenosine receptor blockers such as theophylline or caffeine. So if the patient is taking theophylline, so it will not work and imukoan your adenosine. So toxicities for adenosine include flushing, which is noted in 20% of patients, shortness of breath or chest burning in about 10%. This may also cause induction of high-grade AV block with use of your adenosine and atrial fibrillation. Less common toxicities includes headache, hypotension, nausea, and paresthesias. So magnesium has been used for patients with digitalis-induced arrhythmias who were hypomagnesic. So magnesium infusion has been found to have antiarrhythmic effects in some patients with normal serum magnesium levels. So the mechanism of action is not known, but magnesium is recognized to influence your sodium-potassium ATP sodium channels and certain potassium channels and calcium channels. So it's indicated in patients with digitalis-induced arrhythmias if hypomagnesemic. So kung hypomagnesemic lang ha, if there is hypomagnesemia. So it's also indicated in Torsad even if serum magnesium is normal. So the dose is 1 gram given IV over 20 minutes and then repeated once if necessary. Potassium. So your potassium, the effects of your potassium, if you increase the serum potassium, this can be summarized into a resting potential polarizing action and a membrane potential stabilizing action. So the latter this is caused by an increase in your potassium permeability. So hypokalemia will result in an increased risk of early and delayed after depolarization and ectopic pacemaker activity, whereas your hyperkalemia will depress your ectopic pacemakers and it will slow the conduction. So both insufficient and excess potassium is potentially arrhythmogenic. So potassium therapy is directed towards normalizing your potassium gradients and pools in the body. So that's my last slide. Thank you for listening. Do you have a question? Reyna, pinanmimiraw na ka mo? Sige, you can open your cameras, your videos para kumita iyo. So who will take the screenshot for the attendance?
Doc, nag-screenshot na po ako.
Tapos ka na mag-screenshot? You take now.
Okay po, Doc.
Their videos are already open.
Yes po. Wait.
Kasi ibabangin ito nagmiminulay lat irakuan. Mobile Legend.
Sige, first page po. Next page. Third page. Fourth page. Last page. Done na po, Doc.
Okay, sige. Thank you.
Thank you po.
Thank you, Doc.
Thank you, Doc.
Thank you, Doc.
Thank you, Doc.
Thank you, Doc.